Thank you for joining us today for our webinar. Your commitment to advancing mental health care is truly inspiring. At Iconotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, Iconotes offers a comprehensive solution tailored to your practice's needs. With Iconotes, you can write a flawless note in less than 3 minutes, and without typing a single word. Iconotes was designed specifically to help mental health professionals write comprehensive notes quickly. Iconotes also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at iconotes.com/try-us.
Welcome, everyone. We are so glad that you are joining us today here at Iconotes. We have a special presentation for you today on navigating diagnostic challenges with borderline personality disorder and bipolar disorder. Our special guest today is Katie Bendel, and she's a therapist, writer, public speaker, and community connector. And in her 10 plus years of experience of working in the mental health field, she has come to believe that people thrive in one, authentic, empathetic, and vulnerable relationships with others. 2, sense of safety, physically, mentally, emotionally, and socially. 3, connection to our values, what matters most to us. And as a licensed clinical social worker, she's dedicated her life to helping people access that beautiful triad. She currently divides her time among various professional areas and settings, and her primary attention is with a national mental health treatment facility where she assists in resource development, community education, and facilitating peer-to-peer connection. In addition to this, Katie is also a mental health therapist in a group practice. So welcome, everyone. Welcome, Katie. We're so glad you're here with us today. Thank you, everyone who is posting in the chat to let us know where you're from. I think you're in for a special treat today. We do have a handout there in the handout section of the tabs by the chat, and so you can grab that there. And without further ado, I'm going to hand the mic over to Katie. Welcome, Katie. We're so glad you're here.
Well, thank you so much. I appreciate being invited to speak about this. It is quite the vast topic and a very important topic. So I am, a little anxious, and I hope my anxiety has lent well to helping me prepare well for this and give you all some great information. So let's dive in here. We can go to the first slide. So our agenda for today, we're going to go through a mindful moment to help us all bring ourselves into this space and get focused. We're going to talk about the potential for misdiagnosis with borderline personality disorder and bipolar disorder. We're going to review the diagnostic criteria for BPD, talk about BPD risk factors and triggers. Then we're also going to review diagnostic criteria for bipolar disorders. Bipolar disorder risk factors and triggers. Then we're really going to dive deeper into, okay, now that we've done an overview here, let's compare and contrast. I'm going to talk a little bit about the differential diagnosis nodes and the DSM-TR. We're going to talk briefly about screening and assessment tools, treatment approaches, and treatment outcomes. So we have quite a bit to get through, and we will go through them swiftly. Next slide. Okay, so this is a mindfulness moment. It's called box breathing. And I kind of wanted to do this for myself a little bit, but also for all of you. I know that as health professionals, as caregivers, we take in a lot day to day, week to week. I know you've probably sacrificed some of your time to be here to learn about this. And so with all of that noise going on, I wanted all of us to take a moment just to center and focus in. So I want to guide you through this exercise, and maybe you can even use it with your clients in the future. Again, it's called box breathing. And what I'm going to do is guide you through this box here where you're going to breathe in for 4 seconds, hold 4 seconds, breathe out, hold. We're going to do that just a few times. Normally, I'd recommend a client to go through this for maybe 5 minutes or so, but for the purpose of this, I'm going to lead it pretty quickly. So just take a moment to settle into your chair or wherever you are. Get your feet settled, your hands in a comfortable position. And I want you to breathe in for 4, 3, 2, 1. Hold, 3, 2, 1. Breathe out, 3, 2, 1. Hold, 3, 2, 1. Breathe in, 3, 2, 1. Hold, 3, 2, 1. Breathe out, 3, 2, 1. Hold, 3, 2, 1. Breathe in, 3, 2, 1. Hold, 3, 2, 1. Breathe out. I'm going to take a breath for myself too. All right, so let's dive into the next slide here. I wanted for us to begin this conversation by talking about stigma. And I think I would be negligent if I did not talk about this in context of bipolar disorder and borderline personality disorder conversation. We know that the power of a diagnosis can be wonderful. It can allow folks to understand better what they're experiencing. It allows us to develop a comprehensive treatment plan and measure how effective that is. It really can provide a lot of direction and hope. At the same time, it can provide a lot of misinformation, misunderstanding, discouragement regarding prognosis and outlook. And so in particular, bipolar disorder and borderline personality disorder are highly stigmatized when we look at those compared to other mental health diagnoses. And in the research that I was able to do, I could see that even comparing BPD and BD, that borderline personality disorder is more stigmatized, is one of the most stigmatized, and it's more stigmatized than bipolar disorder. And so when we're thinking about this conversation, I really just want us all to be mindful of maybe the biases that we come in with when we're thinking about the diagnosis. For borderline personality disorder in particular, again, in the research that's been done, what we see is that clinicians often feel overwhelmed and confused, and at times like they don't have the skill set to really approach it. And so, I think sometimes when we look at the instability that can occur, the safety concerns that can occur, the interpersonal concerns in particular that come with BPD, all of that makes the therapeutic relationship really dicey, and it makes it a scary place for clinicians at times. That being said, the more that we educate ourselves, the more that we come to understand, the more skill sets we develop. I do believe that we can reduce that stigma, reduce that bias in ourselves, and feel more confident to be able to help individuals with both BPD and bipolar disorder. And I want to note too that sometimes we may lean more towards a bipolar disorder diagnosis over BPD because of some of the stigma that we know exists. And we may also withhold a diagnosis from a patient. And, that is up to every individual clinicians' discretion, right? When to do that, when it would be helpful. I know for myself that when I've spoken to people with a recent BPD diagnosis, that a lot of them did feel some significant relief, especially when trying to explain to loved ones what's going on with them. Just being able to put words to it was really helpful, to be able to explain, this is what's going on with me, and this is what I'm learning and how I'm learning to help myself. Okay, next slide. Okay, so when we think about potential for misdiagnosis, it's difficult because these two conditions do have a lot of overlapping identical symptoms. So some of those are impulsive behaviors, mood instability and swings, significant shifts in self-esteem, suicidal behaviors or gestures, and dissociation or paranoia. Let me fix my slides here really quick. I've got some notes on the side. I want to make sure I don't forget anything. So in the research, one study indicated that about 40% of patients with borderline personality disorder have been falsely diagnosed with bipolar disorder in their life. And in fact, clinicians are keener to give a diagnosis of bipolar disorder than BPD. This can result in unwarranted prescription medications with a lot of side effects, and it can result in delayed access to efficient treatment. So that is why this topic is so important, and we'll dive a little bit more into that later. Next slide. All right, so diagnosing borderline personality disorder. Let's remind ourselves, I know that some of you may be pretty seasoned, you may have a really good understanding of what this is, but just to remind us all, the Diagnostic and Statistical Manual of Mental Health Disorders, which I will refer to as the DSM from now on because it's a lengthy name. The DSM-5 lists 10 personality disorders that are divided into 3 clusters. There's cluster A, B, and C. Borderline personality disorder is in cluster B. The DSM-5-TR defines borderline personality disorder as a pattern of instability in interpersonal relationships, self-image, and affect, and marked impulsivity. To justify a BPD diagnosis, symptoms must begin by early adulthood and be present in a variety of settings. And in just a moment, we'll get into some of the nitty-gritty of how this looks and kind of the check boxes that you would check as you're looking for a diagnosis. But I do just want to note really quickly that BPD first manifests itself in adolescence. And it can be distinguished from normative adolescent development. So I think maybe 15, 20 years ago, the belief in the mental health field was there's no way to separate that out. People's personalities are not stable until they're 18, and there's just so much going on with identity development and hormonal changes that there's no way that you'd be able to recognize that. But that actually is not true. In the more recent research we've been doing, we are able to kind of distinguish that a little bit earlier on. We're able to see it earlier. And so with that, we're able to try to implement preventative measures from it, maybe fully developing once we see some of those signs and symptoms and risk factors. But definitely, we've learned that temperament, people are born with a temperament that then develops into their personality, and that your personality is pretty stable from early on. It's estimated that about 2.7 of the general adult population has BPD. I think it's interesting to note that about 12% of outpatient mental health treatment includes, about 12% of adults in outpatient mental health treatment have BPD, and 22% of adults in inpatient psychiatric treatment are diagnosed with BPD. And then it's very similar in adolescents, about 1% will develop BPD. And similarly to adults, those percentages are higher in treatment settings. I also want to note really quickly that professionals in the mental health field tend to see women seeking treatment more often for borderline personality disorder than men. Due to this, we might be tempted to assume that women have a higher prevalence than men. That's not necessarily true. Research is telling us that there really is not a significant difference. The reason we might see more women in treatment might be because men are less likely to seek treatment in a clinical setting, but it also could be that because of this misunderstanding that, oh, men don't have this, that maybe they're misdiagnosed, and that gets missed. Next slide. I'm going to try to not bore everyone with these diagnostic markers, but I think it's important to go through them quickly. So for the BPD, when we're looking in the DSM, you're going to see symptoms again in a variety of settings, and you need to be able to check off 5 or more of these in order to diagnose someone with BPD. So 1, a frantic effort to avoid real or imagined abandonment. That imagined is really important. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. So thinking about that, like, I love you, I hate you, you're the best, now you're the worst. Identity disturbance, markedly and persistently unstable self-image or sense of self. Impulsivity in at least 2 areas that are potentially self-damaging. So looking at excessive spending, sex, substance abuse, etc. Recurring suicidal behavior, gestures or threats, or self-mutilating behavior. Affective instability due to marked reactivity of mood. Chronic feelings of emptiness, inappropriate intense anger or difficulty in controlling anger. And then transient stress-related paranoid ideation or severe dissociative symptoms. I think it's important to note that word transient and stress-related. Okay, and we'll move on from there to the next slide. I also think it's important to note that I almost didn't include this because I don't want to confuse everyone, but I do think it's really important to know that there's an alternative dimensional model for diagnosing BPD in the DSM. We haven't quite gotten yet to adopting that fully as a mental health community, but it's something that we're moving towards and that the research is really trying to suss out. So one of the reasons we're looking at an alternative dimensional model is that we're seeing in longitudinal studies that BPD almost always co-occurs with other mental health conditions. So to give you an example of that, we're looking at mood disorders, 80 to 96%, anxiety disorders, 88%, substance abuse disorders, 64%. So those are some of the big hitters: mood, anxiety, substance. Then there's also eating disorders at 53%, ADHD, attention deficit hyperactivity disorder at 10 to 30%, and bipolar disorders in there at 15%. So the dimensional model really focuses on temperament, utilization of defense mechanisms, and pathological personality traits. It's important to note that BPD has a specific distinct feature that is interpersonal and emotional hypersensitivity. So when we're looking at, okay, how do I tell what is what? That's what we're looking for, and we'll talk more about that. BPD reflects general personality dysfunction. And what's interesting is that, a lot of the features of BPD are shared among a lot of different personality disorders. Lastly, just to note, the dimensional model may not require a drastic alteration in treatment methods, but again, we're needing to do more research on that before we fully move forward. Next slide. So to take a look at the dimensional model really quickly, I encourage you to go learn more about this if you're not familiar. But how this looks different from the categorical model, which we went over previously, is within the alternative dimensional model, you've got to see moderate or greater impairment in personality functioning, manifested by characteristic difficulties in 2 or more of the following 4 areas. We're going to look at identity, self-direction, empathy, and intimacy. And again, you have to have 2 or more of those. Next slide. And then you're also going to have 4 or more of the following 7 pathological personality traits, at least one of which must be those last ones, 5, 6, or 7. So we're looking at emotional lability, anxiousness, separation insecurity, depressivity, impulsivity, risk-taking, and hostility. I want to note that I really appreciate this alternative dimensional model. Something that helped me better understand this, that I think might help you if you're not familiar, is almost looking at this as kind of a continuum of personality functioning. So again, moving away from these categories of you either do or you don't have borderline, you either do or you don't have narcissism. It's kind of saying, hey, this is co-occurring a lot in other conditions. And maybe what we're seeing could be better represented just by sort of a dimensional. And so how it was explained to me is if you think about IQ, kind of comparing it to that, like some individuals are at average, below average, above average IQ, trying to think of interpersonal functioning almost on the same level of like, we all have interpersonal skills. Some of us are really great at that, and some of us struggle a lot more in that. And in our personality, we might struggle to regulate our emotions. We might struggle to be able to be look in the gray area and less black and white. And so again, kind of looking at it on like this continuum. The reason I like that is because I think it helps reduce some of that stigma again and brings it back to, you know what, we all struggle from time to time. We all have good personality days and bad personality days, bad relationship days, and that these folks just tend to struggle with that in terms of functionality more persistently and more regularly. Next slide. So BPD risk factors and triggers. There are a lot of theories out there about the development of BPD. My favorite is from Dr. Marsha Linehan. She believes that BPD is the result of genetic vulnerability that interacts with chronic invalidating environments to produce a constellation of borderline personality disorder symptoms. So really talking about genetics and the environment playing a big role here. Folks with first degree biological relatives with BPD are 5 times more likely to develop BPD themselves. And then when we look at the right side, those triggers, what we're saying here is not necessarily what triggers the disorder to onset altogether. It's more of what are some of the symptoms, what are some of the triggers that can exacerbate the symptoms. And you're going to see a lot of this has to do with interpersonal concerns again. So it's rejection and abandonment, disappointment in others, interpersonal offenses and betrayals, isolation, boredom or disconnection to preferred stimuli, and then identity threat. So having your self-concept threatened. And again, I think it's so important. I think when we look at genetics here, it's like, okay, you know, some of the harshest, I guess, thought processes I've heard around BPD is that it's done intentionally just to like cause difficulty, right? Just to get some attention and sort of mix things up. And I think when you look at what are the risk factors here, you're really able to see, okay, so this is really like people actually come into the world genetically pre-wired for this. And then oftentimes they have experiences that sort of trigger that into action, notably adverse childhood experiences ACEs. There's a lot of conversation around how ACEs play into this. There's a big correlation there of individuals with BPD who have a history of adverse experiences, specifically in childhood. Let's see, is there anything else I'm missing here? Well, I guess it's important to say that childhood maltreatment, so physical, sexual abuse or neglect, is found in up to 70% of people with borderline personality disorder, if that number helps, you know. Next slide. So diagnosing bipolar disorders, this is kind of, I will be honest, this is exhausting, right? Bipolar disorder, when you try to look at all the different kinds and what's going on, I'm like, okay, how do I put this into a slide deck? So I tried to break it down here. What's important to note, what I want you to really focus on, is that bipolar disorders present as episodic. Okay, that's recurring mood episodes lasting for a distinct period of time. Symptoms are present every day, most of the day. And it's important to remember that episodes represent a noticeable change from usual behavior or previous functioning. And we'll get into that a little bit more. Bipolar disorder can cause impairments in important areas of functioning, although it doesn't always. Sometimes it can be a noticeable difference, but it might not be an impairment that's experienced. And then the onset can occur throughout the life cycle. So across different studies, we're seeing that the peak is usually at anywhere from 20 to 30 years old. But again, it can occur at any time. And some of the literature suggests that there might actually be like an underreporting of older adults being diagnosed. So that is something to consider in this. Bipolar disorder affects about 8 million adults in the US, approximately 40 million individuals worldwide. Next slide, please. So when we look at, we're going to look at bipolar 1, bipolar 2, and cyclothymia, but I also do want to note that there are additional diagnoses of bipolar disorder not otherwise specified, mixed features, substance-induced mania, unspecified. So those are there. We're primarily going to focus on bipolar disorder 1 and 2 and cyclothymia. So bipolar disorder 1, it's important to remember that it has to include at least one manic episode, and we'll get into that a little bit more. It's going to include a manic or mixed feature episode with or without psychosis and or major depression. So you do not have to have that dip afterwards in order to have bipolar 1 disorder. Bipolar 2 is hypomanic episodes with major depression. So you do have to have a major depressive episode, at least one, and at least one hypomanic episode in bipolar 2. And then cyclothymia is numerous episodes of hypomanic symptoms, but they don't necessarily meet criteria for a hypomanic episode. So they have hypomanic symptoms, but it doesn't meet criteria, again, for a full episode. And then the same thing for depressive symptoms, but not meeting full criteria for major depressive episodes. And this is going to be with cyclothymia, it's going to be a longer presence. So it's occurring over 2 years for adults or 1 year for children and adolescents. Next slide, please. So when we're looking at, okay, what do these episodes look like that make up bipolar disorder? Manic episodes, it's important to know that symptoms must occur most of the day, nearly every day for a full week or more. So again, distinct episodes, manic episodes have to last for a week or more. Manic episodes are severe with marked impairment, possible hospitalization, and possible psychotic features. So when we think about mania, we're thinking of like, you know, increased energy, not needing a lot of sleep, all of these really amazing ideas. Sometimes again, going back to that idea of stigma and bias, sometimes bipolar disorder can be seen as more desirable than borderline personality disorder culturally, because sometimes it's helpful to have these symptoms, is how it's reported. Sometimes it's helpful to have a lot of energy, to not really need sleep. Like if you're an artist and you have a boost in creativity during your manic episode, sometimes we don't really notice that. I don't know what might be going on there. But when we do start to notice is when we're going, okay, this is causing some impairment. It's, there might be some hospitalizations here. And then hypomanic episodes, those have to occur most of the day, nearly every day, for at least 4 consecutive days. And it's hypomanic episodes are very similar to manic. However, there's a difference in severity there. For hypomanic episodes, there's a change in functioning that's observable by others and is uncharacteristic when not symptomatic. However, again, there's that difference. Change in functioning versus marked impairment are slightly different. And then major depressive episodes have to occur for most of the day, nearly every day. And that has to last for a minimum of 2 weeks at least. And there we're also going to see clinically significant distress or impairment. Next slide. I think it's important to note that the risk factors and triggers of bipolar disorder as well. So about 80 to 90% of individuals with bipolar disorder have a relative with bipolar disorder or depression. So similarly to BPD, there is a heavy genetic component here. Most research is signaling to us that risk factors come from a multitude of places with a genetic predisposition affected by stress in the environment. I will say in a lot of the research, there's a big focus on this brain structure and functioning. I will say I'm not the expert in that area, but there is a lot of really interesting research on what's going on in the brain that might be causing risk factors here. When we look at triggers for mood episodes, they are different than borderline personality disorder. If you remember, BPD had a lot of those kind of interpersonal triggers. So it was going back to BPD, it was like rejection, abandonment, disappointment in others, interpersonal offenses. We're not really seeing the same kind of triggers here for bipolar disorder. Again, it's going to be more environmental. So like stress, shift work when you're working odd hours or changing your hours day to day, and there's a lack of that stability. Traveling across time zones, seasonal light changes, sleep disturbance, hormonal fluctuations, and drugs and alcohol can all be triggers. And I think when we're looking at differentiating between the two diagnoses, it's really important to think about this. So if you can think about a case where you've known someone for a while and you're trying to figure out exactly what's going on, looking at the history there. Okay, what's been happening for them over the last couple of months, over the last week? What kind of was precipitating this increase in symptoms? And if you're able to see, okay, this looks more like a stress-induced, like hormonal, maybe some changes in schedule versus for BPD, oh, there's like a significant interpersonal thing that came up. There are, again, different triggers there that I think are helpful to look at and suss out. Next slide, please. Okay, so again, trying to put all this together and compare and contrast. The main takeaways that I want you to leave with today are some of these points here, which are also touched on in the handout that's featured in this, the platform. There's a handout, a PDF handout that goes over some of these. So one of the main distinguishing differentiators is that bipolar disorder is, again, episodic. So there's recurring mood episodes lasting for a distinct period of time. You remember at least 1 week, 4 consecutive days, or 2 weeks. It's this distinct period. Versus borderline personality disorder is a pervasive or chronic pattern of instability that you're seeing over and over again pretty consistently and regularly in relationships, self-image, and affect. There's also, when we're looking at a relation to baseline, for bipolar disorder, there's going to be a pretty noticeable change from usual behavior or previous functioning. And it can cause pretty significant impairments, but it doesn't always. But again, when we're looking at collectively trying to do a proper diagnosis and assessment, if we're able to, and we have consent to bring in friends and family to provide collateral, kind of getting some of that information from them of like, well, when did you start noticing changes? Or would you say that this is like something that they're usually struggling with? Or, and family members of those with bipolar disorder might say it's really out of character for them. Like it's very noticeable when they're struggling. And it's just really not their typical. Versus with borderline personality disorder, it's kind of always consistently there, that impulsivity, that presence and variety of settings. Just on the face value of it, when you think about a mood disorder versus a personality disorder is, again, kind of gets its onset in adolescence, develops at that time, begins by early adulthood, and it's present consistently. So caregivers may say they've kind of always had these underlying problems, or concerns, and maybe it's gotten worse or like increased at different times, but it's kind of always been there. That's borderline personality disorder characteristics. And then again, I kind of already touched on this, but briefly, age of onset, bipolar disorder can occur throughout the life cycle, with that peak probably around 20 to 30. With BPD, borderline personality disorder, the onset's always by early adulthood. Let's see, make sure I'm not missing anything here. Oh, yeah, I just wanted to note that this is difficult, right? Like, just to help us all feel a little bit more normal. Diagnosis in psychiatry is hard because it really depends on observable signs and symptoms rather than biological markers. It would be so helpful if we had a test strip to test these, but we don't, and maybe we'll never get there. And so it's difficult, and it really does take that time and consideration to get a lot of information, and that's not always available, right? Especially in crisis situations, or it's just kind of, if someone's in and out of your care, you're not always able to get that full picture. And so that's difficult. And we'll get into more of what can help you with that in a little bit. Okay, next slide, please. Oh, I think there was one before this. Did something get skipped by chance? Maybe not. Nope. Okay, I must have deleted something on accident, but that's all right, because this is perfect timing. When we're looking at trying to differentiate between the two, again, I wish we had a test strip, but we don't. But we do have a lot of tools and screenings that can guide us, So some of the tools and instruments we might look at for borderline personality disorder are these: the McLean screening instrument for BPD, personality diagnostic questionnaire, Minnesota Borderline Personality Disorder Scale, Personality Assessment Inventory, Borderline Features Scale, Structural Clinical Interview for DSM-5 personality disorders. I believe that iCanotes might even have a few of these, if memory serves me correctly, but I'm sure you could contact them if you're already using this platform. I do believe they have some of these already. I know for sure that they do have some of the screeners for bipolar disorder. So looking at instruments for bipolar disorder, we've got that classic PHQ-9, the Patient Health Questionnaire, the Patient Mania Questionnaire, and then the Rapid Mood Screener and a Mood Disorder Questionnaire. From some of the experience and research I've gathered, I believe the rapid mood screener is favorable and is something that if you haven't looked into yet, I think it would be really beneficial for you to investigate that and look into that as a possible resource. Let me see. Anything else I'm missing here? Oh, yeah. Again, I just want to reiterate that it's not sufficient when we're looking at diagnosis to take a brief history and just to take that and run with the diagnosis. We really have to be comprehensive here in what we're looking at. It's also important to know, and I think we all know this, but it's good to have a reminder that sometimes our patients might be a little bit vague or underreport sometimes the intensity of or the scale. And so just remember that some of these symptoms you can gather based on what you're seeing in your appointments and in your office. It doesn't always have to be their subjective report. It can be your objective experience. And then again, I think, gosh, if you can ever include a family or friend or someone with reliable data and information, how valuable that can be to really get an understanding of what's actually going on. Next slide. Okay, so differential diagnosis. So just to note what's in the DSM that's helping us with this, there is substantial symptomatic overlap, like we mentioned, and when criteria for both are met, both can be diagnosed. So it is possible that you might have a patient with both. And again, about 10 to 20% of patients with either disorder are going to have the co-occurring other disorder. So it's definitely possible. Trying to think of what else we want to note there. I think that's it for this slide. We can move on to the next slide. So we want to really avoid, if we've got someone that already has a diagnosis of bipolar disorder, we really want to avoid giving an additional diagnosis of borderline personality disorder that is, one, made during an untreated mood episode, two, is based only on a cross-sectional presentation, three, lacks documentation demonstrating the pattern of behavior that is at an early onset and had a long-standing course. And then if you've got someone who's already received that diagnosis of borderline personality disorder, you really want to avoid giving them an additional diagnosis of bipolar disorder when the symptoms are not present for distinct episodes or periods or with a noticeable increase over baseline. Yeah, I think that's it for this slide. Let's go to the next one. Okay, treatment approaches. This is why, one of the reasons why differentiating between the two is so important. So for bipolar disorder, medication is the cornerstone to effective treatment for bipolar disorder. That does not mean that medication is the only treatment, but it's a really important factor to implement. Best practice includes a combination of medications and psychotherapy. So some of the medications you might be familiar with that are used to treat bipolar disorder are lithium, Abilify, Lamictal. And then some of the psychotherapy methods might include cognitive behavioral therapy, interpersonal and social rhythm therapy, and family-focused therapy. So again, going back to the stigma piece and misdiagnosis, when we're looking at bipolar disorder, if someone is really needing medications in order to stabilize their symptoms, but we've misdiagnosed them with borderline personality disorder, we're gonna recognize, that that's unfortunate because the medications really are what's needed. And so that can be so detrimental and discouraging for the patient if we're not able to recognize maybe something else is going on here, and maybe they would benefit from a medication. And then for borderline personality disorder, psychotherapy is the cornerstone to effective treatment. So interesting is that borderline personality disorder is not effectively treated by any medication at this time. Now, there are medications to treat those co-occurring disorders like depression, anxiety, etc. But there's nothing that's available to treat borderline personality disorder specifically. And so it is so important to really hone in on that psychotherapy as the cornerstone. I am a big fan of dialectical behavior therapy, DBT, again, kind of spearheaded by Marsha Linehan. And if you're not familiar with DBT, I really highly recommend looking into it, seeing what trainings you might be able to get, because it is excellent for a myriad of things, but specifically borderline personality disorder. And then minimalization-based therapy is another option. My understanding is that MBT is more popular, I think, in the UK than over in the US. I think in the US, we're still really fascinated with DBT. But minimalization-based therapy is really interesting as well. And then we've got transference-focused psychotherapy and schema therapy. Okay. Yeah, let's move on to the next slide. Okay, treatment outcomes for BPD. There was a study that was designed to compare the course of BPD, psychopathology, and social functioning with other personality disorders and with major depressive disorder over 10 years. And within that study, it was a collaborative study of treatment-seeking 18 to 45-year-old patients. And it was followed up with standardized, reliable, and repeated measures of diagnostic remission and relapse, and of both global social functioning and subtypes of social functioning. That was a mouthful, but I want you to understand the context of the study. So again, 290 patients reassessed at 2-year intervals over 16 years, and this was the rate that was discovered. So 35% remission after 2 years, 91% remission after 10 years, 99% remission after 16 years. Once attained, remission persisted over 8 years in 75% of patients. So I think this is a really important narrative to remember, because a lot of time I think people believe that bipolar disorder will borderline personality disorder will never go away, that it's just something that will always be there and that it's basically you're not able to recover from it. But that's just not true based on the research. But with that being said, relapses are frequent. However, 50% of individuals are going to see more full social and vocational recovery. We do see symptom impairments associated with BPD fluctuate throughout life from adolescence to old age. And again, from the research that I've been studying, there's a little bit of a controversy, but some believe that the symptoms improve with age. Others believe that maybe we're just not really studying older individuals with BPD, so we're missing it. But either way, we're seeing decrease in symptoms as people get older. So it's something to further investigate. But appropriate treatment can lead to better functioning and improved quality of life, definitely for these individuals. I was going to say too, unfortunately, within this study, remission was linked to inadequate social connections, with patients possibly seeming to recover by steering clear of interpersonal interactions, rather than through a gradual improvement in social skills. So I think that's important to note. I'm sure we all try to be as comprehensive as we can, but if our patients are reporting, oh, I'm just doing so much better. And, I wonder, we just really need to take a look at, is it possible that they've maybe just kind of pulled back, from social interactions, and that's why they're no longer having as many, concerns. Okay, next slide. So treatment outcomes for bipolar disorder. It varies pretty significantly. We do see a longer duration and increased occurrences of episodes that are linked to higher chances of reoccurrence and are more pronounced impacts on mental and physical health, as well as cognitive functioning. So again, the longer the duration and the number of occurrences of episodes are linked to a higher chance of recurrence and pronounced impact. I hope that made sense. Towards the end, my brain starts to bubble a little bit. Okay, so it is really important to know that most patients require lifelong treatment to reduce relapse rates and improve functioning and quality of life. Unfortunately, non-adherence to medication or, just difficulty being consistent with medication impacts about 60% of patients. And so when we're speaking to patients about treatment and providing psychoeducation, it is so important to really hammer home the importance of staying consistent with your medications. I know it's so tempting for folks to say, oh, I'm feeling so much better, I must not need my medication anymore. But it is so important to stay consistent. And I try a lot to use the comparison of physical health and mental health. Look, if you had a chronic physical health condition that required lifelong treatment with a medication in order for you to feel healthy and be able to function, wouldn't you want to take that? And with bipolar disorder, often we need to have that outlook of this is just what I got to do to kind of keep myself going here. So, but when patients are not able to stay consistent with medications, it's often due to adverse medication side effects, misunderstanding about the need for treatment to feel better, continuous treatment, and then the complexity sometimes of managing multiple medications at once. But again, very much like borderline personality disorder, once we figure out with bipolar disorder what's going on and we figure out that effective treatment method, patients can see significantly improved function and improved quality of life. Okay, I think I'm getting to my last slide here. Next one, please. So moving forward, I recognize that this topic is extremely vast, extremely complex, extremely rife with stigma and misunderstanding. So what I hope everyone took away from this today was simply, hopefully, some reminders about the fact that we all bring in bias and stigma, some reminders of the basic diagnostic criteria, a helpful overview of, okay, here are the 3 primary things I should look at when I'm trying to distinguish between the two. And really just an open-mindedness to consider the way we think about these diagnoses and to maybe invigorate you to look into more research, because both of these, I think the research is, continuing to grow, and especially for borderline personality disorder, we're learning so much. We've learned so much in the past 20 years. And so what you may have learned, 10 years, 15 years ago, there might be some significant differences that are important to consider from between then and now. And I hope that maybe looking at these diagnoses in this way, especially on maybe a continuum, helps reduce some of that stigma and maybe helps improve your confidence in being able to better understand. So that's it for me. I have a lot of references listed here. I have 3 slides of references. And so if you're curious about what I was looking at when I was putting this together, I welcome you to take a look at those. But I would love to take any questions. I know I didn't leave a ton of time. And please be gentle. I have thin skin, I'll be honest. Let me see if I can look the Q&A here. Oh boy, okay. Let me see. Oh. I'm trying to decide which ones to go with. Ooh, can you speak to the historical relationship between pathologizing women's emotions and BPD? Well, that's fascinating. I feel like that could be a whole other presentation topic. Man, I feel like there's a lot to that. I guess what I would say is that, I don't know. I think there's been a lot of research and development over the last 20 years regarding emotions and mental health. If we think about, women being diagnosed and named as being histrionic and put on happy pills in the 50s and like, oh, they're just really hormonal. And, I think that women have for a long time been pathologized for our normal experiences. And I think, again, that's why I like the idea of being on more of a continuum, because yes, there's a lot at play here for adolescents, for adults, and we all, swing a little bit on a continuum, and it's just how much does it impact our life? I don't really know if that answered your question. I feel like that's a whole other conversation. I need to look more into the research, but definitely I think there's something there. What are your thoughts about teens diagnosed with BPD and identifying as transgender? Ooh, those are very two hot topics put together, because there's a lot of controversy about diagnosing BPD within teens. And you can do it, but you have to be super cautious. And from my understanding, what you're really looking at is, does it look like there are enough preventative factors here that they might be able to, for lack of a better word, like grow out of this into adulthood? Like, are their parents slowing down? Are their loved ones able to really validate their emotions and what's going on? Are they involved in extracurricular activities and an opportunity to better cultivate social skills? Like, what is happening here? And so, but if someone really appears to be stuck in that and it doesn't really look like much is going to change, then there might be a possibility that that's just what it is, but it has to be done with a lot of caution. And then teens identifying as transgender. So that's a really hot button topic. I'm assuming what this person is referring to is kind of that, identity disturbance. And I think that probably requires a much longer, broader conversation. But I do think we need to be very gentle and considerate when looking at children and teens who are exploring gender identity, because, we know that invalidating them, not listening to their experience, not exploring that with them, can have detrimental, really devastating consequences, increase in a lot of mental health concerns, substance abuse, suicide. And so it's a complicated issue. I think the best we can do is to continue learning, to be very thoughtful about how we are interacting, asking questions, validating, giving the benefit of the doubt always of tell me more. That should be your question. Tell me more. Okay, I think there's like 2 minutes of thank you so much. For anything I didn't get to, I'm going to try to respond to questions via email, as many as I can. But I think there's a 2-minute iCanotes presentation that we'll end with. So thank you all so much.
Thank you, Katie. It was wonderful to have you. Thanks, everyone.
Thank you for watching today. We hope you enjoyed our webinar. At iCanotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, iCanotes offers a comprehensive solution tailored to your practice's needs. With iCanotes, you can write a flawless note in less than 3 minutes, and without typing a single word. iCanotes was designed specifically to help mental health professionals write comprehensive notes quickly. Iconotes also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at iconotes.com/try-us.